So in this case, we're looking at a 49-year-old male. He presented to the ambulance with the complaints of shortness of breath as well as a heaviness sensation that he was experiencing. All of his symptoms began after he was doing some strenuous activities. I think he was lifting boxes or something. And as you do with any patient with just kind of non-specific symptoms, particularly if they're exertional, is you're going to get a 12-lead ECG. And that's exactly what we did. So we're going to take this ECG and kind of go through it because this one I just found particularly interesting, and it kind of goes on the theme of last video, which was looking at right bundle branch blocks. So first things first, we're looking at rate rhythm axis and any sort of interval issues that are going on. So if we look at lead 2 in particular, we can see that this is a little tachycardic. It's about 109, at least that's what the monitor was calculating. As far as the rhythm is concerned, it does appear to be sinus in nature. There's a P wave, we have a QRS complex, and then right there is your T wave. And it seems to be fairly darn regular. From there, if we look at the axis, we can see that there is a slight right axis deviation. I know lead 1 is a little bit artifacty, and so that definitely makes it difficult, but it seems like there is a bit of a biphasic QRS complex, as you can see right there, and that strongly suggests that there is some right axis deviation or right axis shift. From there, we notice a couple of things. It's kind of a junky looking ECG, as you probably have picked up on this point. You've got a dominant R wave in lead V1, which strongly suggests a right bundle branch block. And considering how the QRS complex duration is being measured at 140 milliseconds, that's 20 more milliseconds than you would need for a normal QRS complex, and this does fulfill the criteria for a right bundle branch block. Dominant R wave in V1, as well as a wide QRS complex, greater than 120 milliseconds. That's our right bundle branch block. Now, as you probably remember from the last video, right bundle branch blocks can be a little tricky because remember, anytime there's an abnormal depolarization of the myocardium, you generally get an abnormal repolarization. And as a result, looking for ischemic changes can be kind of difficult, particularly considering how right bundle branch blocks can sometimes give you false positives and false negatives for ST elevation and ST depression. So with that in mind, let's go through a process that enables us to identify what we're seeing as either normal variant or actual ST depression or ST elevation. And in order to do that, we need to find a lead where we have a very clear picture of where the QRS complex starts and then ends, and then where the ST segment begins and then ends. And if we look at lead 2, I think we can get our answer there pretty easily. Right here is the beginning of the QRS complex. Right here appears to be the J point, and this is obviously the T wave right here. And so if we take the duration in boxes of the QRS complex seen here, we can take that measurement and apply it to any one of these leads and know that that's going to be the same duration of time regardless of which lead you're looking at. So let's look at lead 2. Like I said, the start of the QRS complex is right here. The end appears to be right there, so that's the J point. And if we measure that out, we got 1 little box, 2 little box, 3 little box, which means that our QRS complex should be about 3 little boxes. And if we take a peek at the rest of this 12 lead, particularly looking at the areas where it looks most concerning for ST elevation and ST depression, we can apply this 3-box rule and see whether or not this, for instance, right here, or specifically this right here, is actually elevated, or whether that's part of the QRS complex, but it's just a little, difficult, or it's just like melding into the T wave a little abnormally just due to the very nature of the pre-existing right bundle. So let us find the beginning of our QRS complex, and that's going to be right here. We've got 1 small box, 1 small box, 1 small box, and we know that a normal QRS duration in this particular 12 lead is going to consist of these 3 small boxes, or 3 millimeters, amounting to about 140 milliseconds. And we can see that the end of the QRS, based off of that measurement, is right here. Now, if we take our isoelectric line and draw it across like that, then we know that the J point is right here, which clearly shows that the J point, or where the ST segment begins, is in fact elevated. And it's elevated about 3 millimeters. which is greater than the 2 millimeters required for a ST elevation in the set, or rather a STEMI criteria ST elevation. But we can't usually, or rather, let me rephrase that, we never usually look at isolated ST elevation and formulate a diagnosis of STEMI off of that. We need to have it in a contiguous lead. And so what lead is contiguous to V2? Well, that's going to be V3. So let's blow up one a complex in V3. We've got our P wave here. QRS complex starts right here. And if we count out 1, 2, 3, we can see that the J point is very clearly right there. And if we look at our isoelectric baseline, either through the TP segment, which would be from here to here, or our PR segment, which is going to be from here to here, we can see that it is in fact elevated off of that line as well. And it's about 2 millimeters, a little bit more than 2 millimeters. So this one is checks the box for being a STEMI. Now, based off of just these two leads, we already know that this is positive for STEMI. There's also a compelling history to support the diagnosis of STEMI. And the next thing to look for is the presence of any reciprocal changes. If we look at the reciprocal lead to your anterior leads, which is going to be your inferior leads, such as lead 2 and lead 3, we can see that, at least in lead 3, the start of the QRS complex is like right here. So that's 1, 2, and 3. The J point is somewhere around here. And if you draw a line looking at the isoelectric baseline, we can see that there is in fact depression of about 1 millimeter, and so that is a reciprocal change. We can apply this to lead AVF as well, which is also inferior and a reciprocal lead to the anterior leads. And we see, let's see, I think this is a good one right here. 1, 2, kind of 2, or like 1.5, 1, 2, 3-ish. J point is probably this right here. And if we draw a line looking at the isoelectric baseline, we can see that that is in fact depressed. And so that further reinforces the fact that this is an anterior wall STEMI, just based off of the fact that we have a ST segment elevated view in 2 and 3 with reciprocal changes inferiorly. So it's pretty a slam dunk. This patient ended up having I think an LAD occlusion, was sent to the cath lab pretty quickly, and I imagine had a good outcome. He was generally looking pretty okay, all things considered, and I think did well.